Dear colleagues and friends, it is a great pleasure to give a talk on biofilms, the good, the bad, and the ugly, their role in implant-associated infections. The treatment concept I will present in 7 principles which can be put together in one algorithm. The biofilm formation is common to all implants, from neurosurgical, cardiovascular, to orthopedic and trauma implants. And in all these situations, we need a concept. With a concept, we can prevent aggressive tumor-like surgery, amputation, and even death. And the key to success and to optimal treatment is to combine the diagnosis, the antibiotic treatment, and the surgery directed against biofilms. To help in the decision making, we put together several pocket guides which can be downloadable from this website pro-implant.org and summarizes the most important points which will be presented in the next slides. The first principle is to target biofilms. Biofilms are a very old creature on our planet Earth because they appeared already 2.5 billion years ago, and they resisted to the most difficult living conditions such as high temperature, low temperature, high radiation, and other harsh environments. What bacteria learned in the evolution, they apply it now. When we implant something foreign in our body, then the bacteria can form the biofilm no matter which implant and which bacterium is involved. The typical bacteria for the low-grade infections are those from the normal skin flora, such as Staphylococci and Cutibacterium acnes. Other bacteria which we expect are Staphylococcus aureus, Streptococci and Enterococci, and gram-negative bacteria. Notably, also Candida can produce a biofilm, and often we have also culture-negative infections, which needs the same treatment concept as culture-positive infections. In all situations, it's the same that bacteria within days form a biofilm consisted about 70% of an amorphic substance called matrix, in which bacteria are embedded and protected against antibiotics and our immune system. Speaking about the immune system, we can see here in this movie how efficient granulocytes are in eliminating bacteria. We mixed blood from our PhD student with bacteria from one of our patients and recorded this movie. What we can see is how a granulocyte is chasing the bacterium until it's eaten and killed. This happens as long as there is no foreign body. If, however, we have a foreign body in place, which is not vascularized, then already a low number of bacteria can produce a biofilm, which after 3 weeks is already so mature that the implant needs to be removed, otherwise we cannot eradicate it. With other words, within the first 3 to 4 weeks, we can still eradicate the biofilm despite an infection of the implant by using biofilm active antibiotics. In this movie, we can see schematically how bacteria coming usually from the air can come down to the prosthesis, and as soon as the bacteria touch the surface, they start producing the amorphic matrix, which acts like a glue in which bacteria are attached to the surface and they go into a slowly replicating dormant state. We don't know which prostheses are infected as long as some bacteria from the surface are not detached And because they are free, they are again detected by granulocytes, which can eat them, and due to degranulation of the granulocytes, the inflammation around the prosthesis occurs. This causes loosening of the prosthesis and pain, which is the typical clinical manifestation of chronic infection. Let's go to the second principle, correct classification. Infections which occur in the first month after surgery are acute, whereas those which occurs between 3 months and 3 years are delayed or low grade. The reason of the time difference is that here we have highly virulent bacteria dividing quickly, whereas here we have slowly dividing low virulent bacteria, why we call also this infection low grade infections. We have also a third group, the hematogenous infections, which occur at any time because of the root of infection is not during surgery, but later due to bacteremia, the hematogenous infections. Let's see these three types of infection. Typically, in the early postoperative infection, the wound healing is disturbed. We have a secretion and the patient shows sometimes also fever. This patient doesn't need any diagnostic. He needs a surgery with change of mobile parts. In chronic infections, we have a different situation. This is an example of a patient who has severe pain 4 months after implantation of her hip prosthesis, despite a normal CRP and no radiological abnormalities. A puncture was done, and in the synovial fluid, elevated leukocyte counts were found. So the low-grade infection was confirmed, and because we are 4 months after implantation, a retention is not possible. The prosthesis needs to be exchanged, which can be done in 1 or 2 stages. The third principle involves the diagnostic principle, which will be evaluated by Alejandra. I just want to emphasize that the main preoperative investigation is aspiration of the synovial fluid and leukocyte count determination, whereas during surgery, beside tissue samples, the most important is sonication to detect bacteria from the implant. So the joint aspiration should include not only microbiology, but also leukocyte count, which is more important than the pathogen itself. In addition, when we explant a foreign body, we can send it for sonication, which means that bacteria are sonicated for 1 minute at 40 kilohertz to detach bacteria which can be found in the sonication fluid easily. The fourth principle is the surgeon. Because antibiotics alone cannot replace surgery and cause very low cure rates, it's important to speak of a proper surgical intervention. The solution to pollution is dilution of bacteria, which can be done by sufficient debridement. If we do insufficient debridement, so some dead tissue or even cement is left in the prosthesis, in the chronic infections, then this will cause persistence or resistance of bacteria. This brings me to the treatment algorithm for acute and chronic infections. In acute infections, we change only the mobile parts, but keep the prosthesis. Whereas in chronic infections, so symptoms which are longer than 3 weeks, or it's more than 4 weeks since primary implantation, then the whole prosthesis needs to be exchanged. In experienced surgeon, this can be done in 1 stage if the soft tissues and bone tissue are sufficient. In a more complex situation, we choose a two-stage exchange with a short or long interval, but the faster we can reimplant, the better is the functional result and the better is the patient life quality. Typical mistakes done is that during this surgery, not all dead tissue is removed, and that causes a relapse and persistence of infection. This brings me to the fifth principle after surgery, which are antibiotics. We will hear more about the type of antibiotics later, but it's important to realize that duration is 12 weeks, but most of the time we can use oral antibiotics with biofilm activity after the prosthesis is replaced, or if the prosthesis is retained, then we can start with biofilm active antibiotic as soon as the wound is dry. In case of long intervals, when the patient gets the reimplantation several weeks after explantation, then we suppress the infection and start only after reimplantation with the biofilm active antibiotic. This combination of surgery and antibiotics was evaluated over almost 30 years, and if we follow these principles, we can count with about 95% success rate. The type of antibiotic is of course important, and it should have a bactericidal activity. When we switch to oral antibiotic, good oral bioavailability, and if there is an implant in place, it should also have biofilm activity. To make it easier, there is a table of antibiotics suggested for each type of bacteria and resistance. And the evidence shows that 12 weeks is significantly better than 6 weeks, as shown in this prospective randomized study in France, which showed that in specific in the patients with debridement and retention, the 12 weeks was much better than 6 weeks. And several other studies shows that using biofilm active antibiotics, in Staphylococcus this is rifampin, the success is significantly better than when rifampicin is not used. We switch to oral antibiotics typically after 1 to 2 weeks, as soon as we know the pathogen and its susceptibility, the wound is dry, and the CRP is nearly normalized. We switch to oral antibiotics which are very well absorbed. You can see here these antibiotics are all at least 80% absorbed and also goes well in the bone. And the last principle is that we can also combine systemic with local antibiotics, as will be shown by Daniel Perez. And the reason is that we achieve up to 1,000 times higher concentration of antibiotics locally, whereas the systemic side effects are minimal. We can admix antibiotics in bone cement, for example, spacer. More and more, however, we use antibiotics also in resorbable materials, so that all antibiotics is released within a couple of weeks, and we can achieve a complete resorption of the material in case of, especially in case of multi-drug resistant pathogens. With a list of antibiotics which can be used in the pocket guide to cover the most resistant bacteria. I should finish the talk with the importance of interdisciplinary treatment, so that infection becomes a very well manageable complication by combining the expertise of different specialties to achieve high cure rate over 90% in our patients. There is many publications which confirms that a standardized approach can improve the outcome. And there is a nice summary in this article of the main principles as mentioned before. I would like to thank my group in Berlin and would be happy if you have any questions. You can ask them now or write an email. Thank you very much.